Hello, everyone. Welcome to the PAPERI webinar series. My name is Mariam Youssef, and I will be today's moderator. Thank you for joining us for our session on cancer predisposition in pediatric oncology and genetic counseling. I'm delighted to introduce our esteemed speakers, Dr. Nicholas and Ms. Rose McGee. Dr. Nicholas is a pediatric oncologist with 25 years of experience in hereditary cancer and primary immunodeficiency. Currently, she is a full member in the Department of Oncology at St. Jude's Children's Research Hospital, where she serves as a director of the Division of Cancer Predisposition, DCP. The overall mission of the DCP is to provide the best possible clinical care for children and families at increased genetic risk for cancer, while performing clinical and basic research into the biology and treatment of hereditary cancer. Since its inception, in 2015, the DCP has evaluated over 5,000 children with cancer, of whom 17% have been identified to carry a pathogenic germline variant within one or more cancer predisposing genes. Within the division, Dr. Nicholas and her team are carrying out several research studies to first, develop best practices for integrating clinical genomic sequencing into the care of pediatric oncology patients. Second, identify novel cancer predisposing genes. Third, investigating the the psychosocial factors that influence decision making and communication around cancer genetic testing of children. And lastly, elucidate the cellular and molecular mechanisms underlying hereditary forms of leukemia and hyperinflammation. For Miss Rose McGee, completed her genetic counseling training at the University of Pittsburgh School of Public Health. She is a certified genetic counselor practicing at St. Jude Children's Research Hospital in the Division of Cancer Predisposition. She sees pediatric patients and their families in a busy clinic, evaluating and providing genetic counseling for cancer predisposition syndromes. As well, she's involved in clinical and research endeavors that explore incorporation of genomics into clinical care and impact of cancer predisposition syndromes and associated surveillance on patients and families. So please join me in welcoming Dr. Nicholas and Ms. McGee. Please note that we will have a live Q&A session at the end of the webinar. You can write your question in the chat to submit your questions. Please mute your microphones. Also, this session will be recorded and will be available on our YouTube channel. Dr. Nicholas and Ms. McGee, the floor is yours.
Thank you so much for that kind introduction. It's truly an honor for Rose and I to be here. Hold on 1 minute. I'm trying to figure out how to make this go away. What do I do? Minimize. Yeah, it won't go away. I think we'll just hide it in the corner. There we go. I'm going to put it up in the corner here. So anyway, thank you so much for the kind introduction. It's truly an honor to be here. And Rose and I look forward to speaking with you about genetic predisposition to cancer and genetic counseling as it relates to pediatric oncology. And during today's presentation, we hope to describe some of the latest advances in the field and how the information gained can be used to improve the lives of children and families at increased genetic risk for cancer. So as a brief outline of today's presentation, we will begin by discussing some of the general principles of cancer predisposition, including the prevalence and spectrum of germline mutations in children with cancer. We will then move on to describe the implications of cancer predisposition. So why is it important to identify those who harbor an underlying predisposition? Rose will discuss how we can identify children with cancer predisposition, taking into account certain clinical, tumor and family history features. And then we will finally close by discussing considerations surrounding the genetic counseling related to cancer predisposition testing. So as an introduction, in my mind, I always love to talk about hereditary retinoblastoma. So the concept of hereditary predisposition to cancer has been recognized for centuries, initially through the identification of rare familial clusters of cancer, but our true understanding of the molecular basis of hereditary cancer predisposition did not emerge until the study of retinoblastoma in the late 1900s. And so as we all know, retinoblastoma comes in both a hereditary and a non-hereditary form, where children with the hereditary form tend to be younger at diagnosis and have bilateral eye involvement. Occasionally, in about 10 to 15% of cases, there can be a positive family history. This, of course, is in contrast to those with sporadic retinoblastoma, where they tend to be older and only have a single eye involved. Now, seminal insights were put forth in 1971 when Alfred Knudsen proposed his two-hit hypothesis of tumor formation to explain the distinctive clinical features of hereditary versus non-hereditary retinoblastoma. And according to Knudsen's hypothesis, children with hereditary retinoblastoma, of course, are born carrying a mutation in a gene that's critical for controlling cell growth in all the cells of their body. So this, of course, is the first hit. And Knudsen proposed that if a mutation were to inactivate the remaining copy of that gene in a developing retinal cell, that cell would then become susceptible to tumor formation. So since children with hereditary retinoblastoma already carried the first hit in all the cells of their body, they would be more likely to develop tumors at a younger age and in both eyes. Now, this, of course, is in contrast to children with sporadic retinoblastoma, where both copies of the gene need to be inactivated within a single retinal cell. And since these events are quite rare, patients with non-hereditary disease would tend to be older and have only a single eye tumor. Now, Knudsen's hypothesis was proven true in 1986 when Stephen Friend identified that children with hereditary retinoblastoma carry germline mutations in the retinoblastoma gene, RB1, the first cancer predisposition gene to be identified. So since this, seminal observation, we now know that cancer predisposition syndromes, here denoted as CPS, are caused by germline pathogenic or likely pathogenic variants in hundreds of genes, and that these variants impact critical cellular pathways, including those controlling cell proliferation and differentiation, the DNA damage response, and intracellular signaling pathways. And by and large, right, the majority, probably 90 to 95% of hereditary cancer syndromes are due to inactivating mutations in tumor suppressor genes, and perhaps 5 to 10% are due to activating mutations in growth-promoting oncogenes. But all told, these cancer predisposition syndromes comprise a wide array of rare conditions, each with its own unique spectrum of cancers and non-oncologic manifestations. And over the last, 2 decades, it has become increasingly apparent that identifying individuals with an underlying cancer predisposition syndrome can greatly inform clinical practice by guiding strategies for cancer treatment, surveillance, and prevention. And I'll touch upon some of these today. And then, of course, germline information can inform genetic counseling and testing of other family members. And Rose will be touching upon that later in the presentation. So despite, the burst and discovery of cancer predisposition genes around the turn of the century, when I joined the faculty at St. Jude now 10 years ago, little was known about how often these genes are actually mutated in the germline of children with cancer. And to begin to address this question, I had the great fortune of working with Dr. Jingwei Zhang, who at the time was the chair of the Department of Computational Biology at St. Jude, in analyzing germline data that had been collected through the Pediatric Cancer Genome Project, which was a longstanding collaborative research effort with St. Jude and Washington University. And in the PCGP, tumor and germline samples had been sequenced from over 1,120 children with poorly understood or difficult to treat cancers, including high-risk leukemias, brain tumors, and solid tumors. And in terms of the germline data, so germline samples were analyzed using whole exome and or whole genome sequencing, and essentially 60 genes associated with autosomal dominant cancer predisposition syndromes of moderate to high penetrance were comprehensively analyzed. And variants that were identified were initially classified using an automatic pipeline that Dr. Zhang developed. Subsequently, the variants were reviewed by a panel with a final classification of pathogenicity. And through this effort, 95 of the 1,120 children, or 8.5%, were identified to carry a germline pathogenic or likely pathogenic variant within one of these 60 genes, with, of course, the prevalence of variants varying depending upon the tumor types that the children had, with variants lowest in those with leukemia and neuroblastoma, and highest in those with adrenocortical carcinoma. And as Rose will be discussing later, adrenocortical carcinoma is one of the defining tumors for patients with Li-Fraumeni syndrome, which is caused by germline mutations in p53. So since this PCGP germline study, several other large, non-biased germline sequencing studies have been completed, and altogether, these studies have shown that between 6 and 20% of children and young adults with cancer harbor a germline variant in a cancer predisposing gene. And as you might imagine, the more genes that are evaluated, the higher the prevalence of variants. To put this number in perspective, if one considers that each year, approximately 400,000 children and 20 million adults are diagnosed with cancer globally, the calculation would, predict that each year up to 80,000 children and 4 million adults with cancer globally would harbor an underlying predisposition. And this number only amplifies if one considers that these individuals are members of families, where there might also be additional genetically affected individuals. And as I look to the future, I know these numbers and proportions will only further increase. And I say this because up until now, most studies have primarily investigated for highly damaging mutations in known cancer predisposition genes of moderate to high penetrance. Nevertheless, it's very likely that a subset of cancers results due to the combined effects, perhaps of weaker or less damaging mutations in 2 or more genes. Further, variants in modifier genes, gene-environment interactions, and variants in non-coding regions of the genome, such as promoters, enhancers, introns, or alternatively, epigenetic alterations, will also contribute, to childhood cancer risk. So I imagine moving forward, host genetic factors will play an even larger role than we know today. So having, explained the prevalence and spectrum of mutations, why is it important to identify patients with an underlying cancer predisposition? And of course, there are many different reasons, some of which I will touch upon here. So patients with germline predisposition may benefit from the use of targeted therapies. Some of the examples, that exist now for FDA-approved medications include the use of selumetinib, a critical MEK inhibitor for patients with neurofibromatosis type 1, belzutifan, which is a HIF inhibitor in patients with Hippo-Lindau associated tumors, and of course the use of PARP inhibitors for adults with germline BRCA1 and BRCA2 mutations who have ovarian, breast, and prostate cancer. In addition to directing targeted therapies, germline information helps us to know when to avoid certain treatments, such as the use of radiation in children with hereditary retinoblastoma or certain DNA damage disorders. Similarly, chemotherapy in patients with DNA damage disorders. Fanconi anemia is an excellent example. Patients may also benefit from cancer risk-reducing procedures, such as removal of the colon in those with familial adenomatous polyposis. So this is virtually 100% preventive of colon cancer in these individuals, and removal of the thyroid in those with multiple endocrine neoplasia type 2, where there is a significantly increased risk for medullary thyroid cancer, which is a high-risk type of thyroid cancer. Patients may develop other non-oncologic manifestations that could need medical intervention. Examples include hemihypertrophy, in patients with Beckwith-Wiedemann syndrome, and developmental issues, seizures, many others, and a variety of additional cancer predispositions. And finally, other members in the family might also be at risk. So these are some of the implications. In the next slides, I will show you examples of how germline information has really provided an exciting and new avenue for cancer therapy. For patients with a rare autosomal recessive cancer predisposition syndrome known as constitutional mismatch repair deficiency, and Rose will touch upon this as well in her portion of the presentation. So this condition is due to biallelic mutations in the mismatch repair genes, MLH1, MSH2, MSH6, and PMS2. And children and adults with this condition are at a significantly increased risk to develop a variety of tumors, particularly brain tumors, GI cancers, and blood cancers. And by virtue of the fact that they have biallelic mutations in these genes, their cells accumulate large numbers of DNA mismatches that can't be repaired as cells replicate. And when you look in their tumors, these tumors have a very high burden of exonic mutations. They're called hypermutator tumors. And if you see here in blue, the number of exonic mutations is orders of magnitude higher than what one sees in other childhood or adult brain tumors. Now, it would be expected that these exonic mutations would lead to the production of mutated proteins that could produce new neoantigens against which their immune systems would be expected to react. However, due to the immunosuppressive microenvironment of tumors, this does not happen, and these patients can develop very aggressive cancers. And now this has led to the concept of immune checkpoint inhibition as a way to treat cancers in individuals with CMMRD. And Rose and I were very fortunate to be able to contribute data to a large study that was completed by the CMMRD Consortium. And this study included 35 patients with 45, relapsed or progressive cancers who were treated with immune checkpoint inhibitors. And as can be appreciated here, responses or stable disease were observed in a little over half of the tumors, including CNS tumors in blue and GI and other solid cancers in green. And a beautiful example is shown here where we have a brain tumor pre-immune checkpoint inhibitor that then has resolved to a large extent following immune checkpoint inhibition. Importantly, increased responses were associated with prolonged survival. And as might be expected, the responses were proportional to how many, T cells were in the tumor and how high the tumor cell PD-L1 expression was in the lesion. In addition to informing targeted therapy, germline information informs our understanding of subsequent cancer risks. And I show you here a study by my colleague Xiaoming Wang from the Department of Epidemiology and Cancer Control at St. Jude. And what Xiaoming did was sequence the germline of over 3,000 adult survivors of childhood cancer. And he looked for mutations in those same 60 cancer predisposing genes that we evaluated in the Pediatric Cancer Genome Project. So Xiaoming identified patients with and without mutations in these genes, and then he looked to see how these mutations correlated with the development of subsequent malignant neoplasms. And as can be shown in the graphs, the presence of germline mutations significantly increased the risk for subsequent cancers, so shown in blue, with the types of cancers the risk for certain types of cancers differing depending upon the therapies used to treat the children's initial cancers. So patients who had not received any radiation therapy were really at increased risk to develop any type of subsequent malignant neoplasm, whereas those who had received radiation therapy, the mutation carriers were at greatest risk, honestly, for breast cancer and sarcoma. And most recently, Xiaoming has published that in addition to increasing the risk for subsequent neoplasms, the presence of germline mutations is associated with an increased risk of death due to these second cancers. And the reason behind this remains to be determined. So, recognizing that germline predisposition not only increases the risk for primary cancers and secondary cancers, as well as death from these second cancers, there has been great interest in developing effective surveillance protocols. And obviously, the purpose of surveillance is to detect cancers early, where they then can be treated using less invasive therapies, less invasive surgery, or potentially less aggressive or even no chemo or radiation therapy, with the overall aim to improve survival with less morbidity. Nevertheless, there are many lingering questions surrounding surveillance, which is, who do we monitor? When do we monitor? What are the best tests to use? What are the costs and benefits? How can we improve access in places in the world where there might not be advanced monitoring technologies such as MRI of the organ parts like brain or body or whole body MRI? And overall, what are the impacts of surveillance? Does it truly improve overall outcomes and survival? And to begin to address these questions, Rose and I had the great fortune of meeting with 65 other providers in Boston in 2016 as part of a special AACR, Childhood Cancer Predisposition Workshop, focusing on developing surveillance recommendations for children with underlying cancer predisposition syndromes. And this led to the development of a series of open access papers with recommendations that are currently being updated. We met again in 2023. And these recommendations can be found here in this link as a series of articles available to all. In addition to the efforts through the AACR, both SIOP Europe and the European reference networks have information regarding guidelines for the evaluation, management, and surveillance of children with a variety of cancer predisposition syndromes. And I put these here for your reference. Now, one thing that has become apparent through these various efforts is that aside from 2 or 3 individual cancer predisposition syndromes, the data demonstrating efficacy of surveillance for children with underlying cancer predisposition is very limited. Therefore, most protocols are developed based on, expert opinion more than anything else. And to try to, close the gap in the field, gain more information, I was very lucky to work with 2 members of my team, actually the entire team, but Elise Blake, a genetic counselor, and Will Soprino, junior faculty, spearheaded an effort to examine, the impact of surveillance for 274 children who underwent syndrome-specific standardized surveillance protocols through our cancer predisposition clinic here at St. Jude. And this just happens to show the different types of cancer predispositions these children have. And through this study, they made several impactful findings. First, at a median of only 3 years of follow-up, they identified 35 tumors in 27 patients. So this is 10% of the total cohort. So the fact that they identified, a significant proportion of patients developing tumors in a short time frame really supports the potential utility of surveillance, which I am hoping will enhance utilization of surveillance by oncology providers, and also in our country and others that have insurance authorization for surveillance testing. Second, they noted that almost a third of new tumors were detected on the very first surveillance scan, and almost a fifth in patients who are actually undergoing therapy for an existing cancer. So these are patients who developed a new cancer while undergoing therapy for an existing cancer. And this too is very important because often oncologists will wait until after a patient has completed cancer therapy before starting surveillance for new cancers. So this tells you really need to do it as soon as you ascertain that a child has a predisposition. Third, tumors detected on surveillance were more likely to be localized than tumors prompting the initial cancer predisposition syndrome diagnosis. In these cases, it was usually based on symptoms. And importantly, a majority of tumors for which surgery was used as a therapeutic modality were completely resected with negative margins. And this is critical, of course, because the outcomes for patients with certain brain tumors and solid tumors depends on good local control. Finally, across all imaging modalities, there was excellent performance with strong sensitivity, specificity, positive and negative predictive values. Now, that said, surveillance was not without its challenges, and I'm pointing out a few of these challenges here. In a small number of patients, tumors were diagnosed between surveillance visits, and in all cases, this was based on clinical symptoms or findings. In 10 patients, lesions were identified on surveillance, but they were of indeterminate status. We didn't know, were they malignant or were they benign? And so these patients needed, serial monitoring. If the tumors grew and ultimately were biopsied, then we would establish what they were. So there are cases where we just don't know what they are. And finally, actually in 2 patients with Beckwith-Wiedemann syndrome, they had rising biochemical evidence of potential tumors, so AFP, which can be indicative of hepatoblastoma. But when they had imaging, we couldn't see the lesions. So the lesions were too small to find, and we had to wait and repeat imaging before we could find the tumor to remove it. And then finally, there's the issue of false negative and false positives findings. And I just show you here two examples of each of these. So the first is a false negative finding. This is a 10-year-old girl with constitutional mismatch repair deficiency and B non-Hodgkin lymphoma who had a baseline brain MRI done as part of her therapy following treatment for her cancer. It was part of her protocol. And there was a subtle asymmetry noted in the occipital region that was read as treatment-related leukoencephalopathy. A follow-up scan was done with the same reading. Unfortunately, several months later, a repeat scan revealed a glioblastoma. So clearly, this had been a tumor in evolution and likely should have been biopsied sooner. On the other side, I show you an example of a false positive finding. So this is a 4-year-old boy with Lee-Fraumeni syndrome and a history of adrenocortical carcinoma who was undergoing routine surveillance and had an abnormal marrow signal concerning for malignancy on his whole body MRI, as well as on a follow-up dedicated MRI of the hips. He was asymptomatic, and his family decided simply to follow. And lo and behold, 2.5 months later, the abnormal signal resolved. So this tells us that, for those who have tumors detected under surveillance, outcomes are relatively good. Nevertheless, we still need to better understand the age and tissue-specific cancer risks and develop improved screening methods so that we can catch more tumors and minimize these risks for false negative and false positive results. So with that said, I am now going to turn my computer over to Ms. McGee so she can talk about identifying individuals with cancer predisposition.
Right. Thank you, Dr. Nichols. So we've talked a bit about why these are important, right? And so next we'll review how are we identifying children who have cancer and have these underlying genetic conditions. I will say we'll focus on children with cancer because that's where we're practicing, but the concepts that we talk about here are also applicable in families with cancer or also adults with cancer. And so there's three major categories or factors that we think of that may warrant a referral or concern for underlying cancer predisposition. And those are first family history of the patient, but also the patient's tumor type and potentially the tumor genetics. And also sometimes, not all the time, clinical features, physical or other developmental history that may point to a particular condition. Recognizing that in some situations, the presence of just one of these factors is sufficient to warrant evaluation. So an example of that, one that Dr. Nichols mentioned earlier, was adrenocortical carcinoma. Just given that tumor diagnosis alone, independent of any family history, there's a recommendation to evaluate for underlying predisposition. In contrast, for other cases, it may be that there's more than one factor that would be needed to really trigger a concern for any particular genetic conditions related to cancer. And so we'll go through each of these categories next. So in thinking about family history, in our practice, we do truly take a 3-generation family history. And one of the reasons why is because our patients are often very young. And so their parents are young and therefore their grandparents are young. So we try to take a comprehensive family history that covers those first, second, and potentially third-degree relatives. And we're targeting our family history in particular to cancers or tumors. If the family knows what type of cancer relatives have had, how old were they at diagnosis, is there any bilateral multifocal tumors in people who've had cancer, and if the family knows what kind of treatments did they receive. As well, are there any physical or developmental features that may fit with a particular cancer predisposition syndrome? We also like to ask, especially for close family members, are there other health or mental health conditions that may impact our assessment, but also impact our work with the families over time? And lastly, we do ask about consanguinity, right? Are parents related by blood? This is especially important if we're considering cancer predisposition syndromes that have a recessive inheritance pattern. And so once we've collected that family history, we have to realize, right, that family history is dynamic. It changes over time. And so it must be updated over time. And that's an important recommendation we have for ourselves, but also for the oncologists that refer patients to our clinic. And so once we have that family history, what are the features that are suggestive to us of cancer predisposition? One is to see that there are multiple family members affected with cancer, particularly on one side of the family. Are there family members who have been diagnosed with cancer at a much earlier age than we tend to expect for that cancer type? Is there anyone with bilateral or multifocal cancers in paired organs? Is there anyone with multiple primary tumors? Or is there a constellation of tumors that could all fit within a certain cancer predisposition syndrome? And might there be certain non-oncologic features, developmental or physical clinical features that could be suggestive of a syndrome? And so all of these are things that may be more suggestive of underlying cancer predisposition. With an important caveat in our patient population is that among children with cancer identified to have cancer predisposition across these the numerous studies that Dr. Nichols showed earlier, we've seen that around half, so 40 to 60% of those patients have a negative family history, meaning there was really none of these features that were clearly obvious looking back at the family histories. And there's a number of reasons why that would be. Some are just biological. For example, the certain genetic condition is most likely to occur as de novo, meaning the patient's the first person in the family to have it, but also social. Sometimes families don't know about their family history, or there may be small families, so there's not an opportunity for a genetic condition to fully present itself within the family. Outside of family history, we also think about the tumor type itself that the child has. So there's a number of tumors for which, independent of other family history or even clinical features, recommendation to evaluate for cancer predisposition. So here I'm just showing you examples across the different tumor types. So hematological malignancies, solid tumors, and brain tumors. This is, again, not exhaustive, but these are all tumors for which there is a high enough risk or chance to identify cancer predisposition just based on tumor type alone. And so the recommendation would be to evaluate children with these tumors. Also, in children who have early onset cancers that typically occur in adults and not in children, that's a big clue for underlying predisposition. So example of that would be colorectal cancer in a child. Also, children who've had multiple primary tumors is another red flag for us for underlying cancer predisposition. Increasingly, tumors themselves are being sequenced and genetically evaluated. And so for oncologists who are ordering tumor genetic testing, often that's happening just on the tumor sample. And so it's very possible that the tumor genetics can point out variants that are actually germline in origin. And so next I'll review some of the features of variants reported in tumors that actually could be suggestive of cancer predisposition. So one is just to see a variant in a gene of germline relevance. So a variant in a gene that is known to be associated with a cancer predisposition syndrome, and that variant or that gene may or may not be expected given the tumor type. If we're seeing a variant in one of these types of genes with a frequency hovering around 50% or around 100%, that's also suggestive. Seeing two variants in a tumor suppressor gene can be suggestive of a second hit. So an example that Dr. Nichols showed earlier is the RB1 gene. We tend to expect two hits in that tumor, and often there can be one of those hits can be germline. If we're seeing the same variant in two different tumor samples from the same patient, if we're seeing a founder mutation, so a founder mutation in the germline context is a variant that is seen at a higher frequency in certain populations, but it's known to be associated with cancer predisposition. Those in a tumor genetic test report or genomic report are highly suggestive of germline origin. And lastly, pertinent to the pediatric population, there may be tumor DNA mutation patterns. So not necessarily one individual variant itself, but a pattern of mutations that can be suggestive of underlying cancer predisposition. So an example that was discussed earlier is a hypermutator tumor in a pediatric patient with cancer is suggestive of underlying replication repair defect. And we'll get another example of that later. Lastly, some cancer predisposition syndromes have clinical or physical features or developmental features that can also be an underlying clue to the diagnosis. And importantly, these features can precede a cancer diagnosis. So if they are picked up or medical attention is brought to those before a cancer predisposition diagnosis, that's the ideal. And of course, that's not always possible. And so here I'm just showing you different categories of areas of body systems that we ask about and we think about in diagnosing cancer predisposition syndromes. And I'll bring attention especially to skin. So children with cancer, it is very important to check their skin because many of these cancer predisposition syndromes actually do have cutaneous features that are a signal to the presence of the genetic condition. Another point I'll make here is sometimes we're seeing patients well after they've had treatment. And sometimes the treatments themselves can impact development, cognitive functions, and can even can impact physical development. And so there can be features that are important to disambiguate from, was it something that was caused by the treatment, or is this a feature that actually goes with a particular cancer predisposition syndrome? And so again, for a child who has cancer plus any range of these features is somebody that we would want to have evaluated for cancer predisposition. Next, I'm going to hand it back over to Dr. Nichols. She's going to review some of the physical exam findings.
There we go. Yes. And so as Rose mentioned, dermatologic findings, including café au lait macules, are a major indicator of an underlying predisposition. So café au lait macules, of course, are flat, hyperpigmented spots on the skin with distinctive borders. These can often increase in size and number as children age, and they are seen most frequently in children with neurofibromatosis, but can also be seen in individuals with CMMRD, Fanconi anemia, and certain RASopathies. And while these are not, as a single entity pathognomonic for NF1, they're a real indicator to at least consider looking for NF1 and these other conditions in a child with or without cancer. Very important finding. Other types of skin findings include freckling. So in those with NF1, you can have axillary or inguinal freckling. You can have mucosal freckling, so freckles on the lips or in the perianal region in individuals with a syndrome known as Peutz-Jeghers syndrome, and freckling on the penis in males with P10 hamartoma tumor syndrome. Other skin findings include pits and cysts. So these are a little bit hard to see, but these tiny little pits on the palms of the hand and soles of the feet can be seen in individuals with nevoid basal cell carcinoma syndrome, also known as Gorlin syndrome. And you can have epidermal cysts generally on the head and neck, rarely on other parts of the body, in patients with familial adenomatous polyposis. Now, eye findings are another common finding with certain cancer predispositions, and I show you a few examples here. So in von Hippel-Lindau syndrome, you can have retinal hemangioblastomas. In ataxia telangiectasia, of course, you can have, skin as well as conjunctival telangiectasias, excuse me. In familial adenomatous polyposis, you can have freckles on the retina, known as congenital hypertrophy of the pigmented retinal epithelium. And in neurofibromatosis type 1, you can have these little hamartomas on the iris, known as Lisch nodules. Additional eye findings include aniridia, which can be partial or complete. This is often, part of the syndrome known as Weger syndrome, Wilms tumor aniridia, GU malformations, and range of developmental delays syndrome. And finally, skeletal features. I show you one example here for children with nevoid basal cell carcinoma or Gorlin syndrome, where you can have a variety of findings, including calcification of the falx cerebri, jaw keratosis, so these can impact eruption of the teeth, and then vertebral abnormalities. And here you can see there are some wedge vertebra. So these are all various physical manifestations of these different cancer predisposition syndromes. Now, recognizing that, there is an increasing number and complexity of cancer predisposition syndromes, it's imperative that children and families with these conditions be managed by or in consultation, let's say, with individuals or providers who have expertise in these syndromes. And in the next slides, I just wanted to highlight that we have formed a clinic here at St. Jude, whose overall goal is to combine the state-of-the-art clinical care with research to enhance the outcomes for children and families at increased genetic risk for cancer. And central to our program is an outpatient clinic that in which we try to evaluate, each new child accepted to St. Jude with cancer, where we do exactly what Rose mentioned. We evaluate for genetic risk by collecting personal medical family history and doing a physical exam. We provide genetic counseling and testing. For those who test positive, we coordinate cancer screening. The counselors do an excellent job providing psychosocial support and assist with counseling and testing of first-degree relatives. And when available, we'd love to offer patients enrollment in, St. Jude as well as external research studies so that we can further advance the field. We also have generated additional resources that are available on the web for our own use and use by external parties. So these are available for you. We have information on 20 of the commonest cancer predisposition syndromes, including the underlying genetics, the cancer risks. We have a weekly case conference where we welcome others to present cases if they have questions, and we can provide consultations as needed. We can be reached at gpteam@stjude.org. In addition to our clinic, there are several other resources available to you and others, including resources that will help to identify children with cancer who might best benefit from a genetics evaluation. These include resources. One is called the MyPOG or McGill Interactive Pediatric Oncogenetic Guidelines. This is a phone or web-based application where you punch in information about the child's tumor type as well as other clinical features, and it will tell you whether or not that patient would benefit from a referral, so they can be reached at www.mypog.com. In addition, the Children's Oncology Group and this group here in Europe have developed other guidelines that will help in identifying patients who warrant referral for genetics evaluation. So now I turn it back to Rose for some genetic counseling considerations.
All right. Thank you, Dr. Nichols. Just to provide a little bit more background on genetic counseling. So one definition or description of genetic counseling is that that is a process, right, of helping families understand, adapt to the various implications or consequences of genetic conditions. And so as a genetic counselor, I am using that process to provide interpretation. So evaluating the family and medical histories, providing risk assessments and evaluations, providing education about genetic testing options, or if we've made a diagnosis, providing information about the genetic condition, what are options for management or prevention, and also providing resources and research opportunities to families. We also provide counseling. So one in just helping in decision making, helping families make decisions about testing or next steps after testing, but also to provide short-term psychosocial support after we have made a diagnosis. And so in the pediatric cancer space, our clinic is often a space where families are asking sort of classic questions after the child has been diagnosed with cancer. And so the ones we hear often are first, why my child? Or it could actually be the patient themselves asking that, why me? Why did I get this cancer? Will it happen again? And what about my other children? Or if the patient's asking, what about my siblings? And so these, again, are very common questions or themes that we get asked in our clinic. And sometimes we're able to give a very distinct answer to families. Most of the time, though, we are not. So next, we'll talk a little bit about germline testing approaches in pediatric cancer. First, by and large, most germline genetic testing in this population is being ordered based on clinical concerns. So factors that we've discussed earlier are present, and so testing is being ordered. Other centers have transitioned to more of a universal testing model, meaning any child diagnosed with cancer is offered typically a broad genetic test, regardless of whether there's any specific concerns for cancer predisposition. Ordering providers for germline testing tend to be the oncologist or genetics providers or potentially other providers. And one small point for thinking about samples is that for children who have active leukemia, we have to think about a different sample, a non-blood sample, typically skin, whereas for children with solid or brain tumors, a blood sample is usually acceptable for germline testing. What about consent? So ideally, we want that to be informed, meaning the family has an idea of what is the testing for and what can the testing tell us, and also, of course, a plan for how those results will be conveyed to the family. As far as types of testing, there are lots of different genetic tests. The tests that we focus on most and will focus on today are sequencing tests. So next generation sequencing tests that typically or hopefully can evaluate also for copy number changes, deletions, and duplications. There may be other test types that are needed to detect deletions and duplications, but both sequencing and copy number variants are important to constitute a full evaluation of cancer predisposition genes. And so most commonly in this population, either single gene testing or multi-gene panel testing is what is being ordered. Less common, we have genomic sequencing, broader sequencing approaches like whole exome and whole genome. And then types of results. So the testing's been ordered, and now what possible results might come back. And so, of course, the first possibility is a positive test result. So there's a pathogenic or likely pathogenic variant in one of the genes that confers a diagnosis of a cancer predisposition syndrome. And so this is an actionable result. We'll take the next steps to talk to the families about whether this would change anything for treatment, talk about surveillance, and talk about what are the impacts or implications for family members. A negative result is usually reassuring. It means no variants were detected, though it's an important space to think about limitations of the testing, meaning was there a different genetic condition that just wasn't included on the test that we're concerned about, or is there a different test that needs to be ordered to be able to diagnose a different genetic condition that may be pertinent to the family or to the patient in front of us. And lastly, variants of uncertain significance. So these types of variants are variants where there's not enough data to say whether this variant is causing an increased risk for cancer or not. And so typically in clinical practice, we are not taking any next steps on these. We're not making any medical changes either for the patient or for the family for these. And we do recognize that variants of uncertain significance may disproportionately affect people who come from ancestries or backgrounds that are not well represented in population genomic databases. And so we recognize that we are practicing in a very resource available setting. And so we have some considerations that we pulled together to think about cancer predisposition in resource limited settings. So one is that a clinical diagnosis of a cancer predisposition can be established without genetic testing for some of these conditions. So examples include hereditary retinoblastoma, where having retinoblastoma in both eyes, bilateral disease, is a clinical diagnosis. As well, a clinical diagnosis of Beckwith-Wiedemann spectrum can be made if the child has a certain number of features of that condition that are just evaluated based on physical exam or clinical history. As well, Dr. Nichols showed some referral tools. So using those tools to identify those with the highest likelihood of coming back with a positive genetic test in settings where access to genetic testing may be limited or not available for all patients. As well, there's a number of international registries for specific cancer predisposition syndromes that may offer gene or other diagnostic testing through registry enrollment. And so I'll show some examples on the next slide. And for those patients or families where there is a suspected or a confirmed cancer predisposition syndrome, there may be limited access to surveillance or screening tests. But in that setting, and we're trying to be better about that here, right? Regular physical exams and education to the families about what are the signs or symptoms of concern that may point to a new cancer or tumor is critical to help make sure the family follows up if there is a concern outside of screening. Dr. Nichols also showed, right, that there are open access surveillance recommendations that can be used to guide screening strategies, especially in settings where there may be limited access. And lastly, I did see in the literature several pilot studies looking more in detail at this concept of cancer predisposition in resource-limited settings. And so I've given you several studies to look at if this is of interest to you. But some of the themes that emerged from reading them are, one, just securing funding for these, whether that's through national groups or through private grants or collaborations. And from that initial pilot, demonstrating efficacy, but also adjusting for the setting, adjusting based on the local access to different modalities, but also to the culture. Here, I'm just showing you some examples of cancer predisposition groups that either provide advocacy or enrollment, and that may be able to help provide further support to providers and families for these conditions. And so next, with time, if we're doing okay on time, I'll walk through quickly several cases, right, just to pull all of these concepts and ideas together to give you a feel for how this might work. And so the first case is Nathan. He came to our clinic at age 7. He had a history of pineoblastoma, diagnosed at age 3, and he came to us having completed therapy, which was chemo, radiation, and surgery. He did have mild neurocognitive disorder, hypothyroidism, and hearing loss, and these were clinical features that were important to think about, but largely these were attributed to his prior treatment. But the family really came to us with the question about the family history. So his mother and then multiple maternal family members had significant history of thyroid nodules or thyroid cancer. And so Nathan's mother came to us with this question saying, there's something running in my family. I just don't know what it is. And so we were able to recognize that combination of the thyroid nodules, thyroid history, and the pineoblastoma were concerning for Dicer-1 syndrome. And so we offered evaluation for that condition. And we were able to give the answer back to the family, which was that Dicer-1 was the answer of the thing that was running in the family. A bit about Dicer-1. It's a dominant condition, mostly inherited, and the cancer risks seem to be highest at ages under 40. But it seems to be a lower penetrance cancer condition, meaning the cancer risks potentially approached 20% by age 50 years. That's from looking at non-probands. But in Dicer-1, thyroid cancer, thyroid nodules are very common in the general population and are highly prevalent in Dicer-1. However, all the other cancers tend to be rare childhood cancers, and so you may not see many instances of that in a family. But the classic tumors are lung, kidney, and ovary tumors, and less commonly other tumors impacting other body systems. And it's an evolving phenotype. We're continuing to learn more about Dicer-1. And so to think about surveillance, once we've made that diagnosis, we're doing imaging, targeting the areas at highest risk for Dicer-1 tumors, and that the frequency and the types of imaging we do depend on the child's age and the sex of the child. So for Nathan, he underwent baseline Dicer-1 surveillance, and right at the first exam, illustrating from our study about surveillance that we found, right at that first exam, he had a large thyroid mass, which ended up being papillary thyroid cancer. So the diagnosis of Dicer-1 was critical to be able to find that second cancer at an early stage. Next, we're going to talk about Elizabeth. So Elizabeth came to our clinic at age 13. She had a history of non-Hodgkin's lymphoma diagnosed at 10 years. She had completed her therapy. And she came to us with a significant number of cafe au lait spots. She had much more than 6 of them. They were on her trunk, on her neck, on her back. And the family, Elizabeth and her parents, came to us asking, what are these skin spots? Are they important? Do they mean anything? And largely the family was told, they're just birthmarks. They're not important. And which is true. They're in and of themselves, the cafe au lait spots aren't harmful. And so in taking the family history, we really weren't too concerned. There was a cousin who had a brain tumor, but otherwise family history was largely quiet as far as cancer goes. And so for us, it was really this history of the non-Hodgkin's lymphoma plus those cafe au lait spots. And so through further evaluation of Elizabeth, we did confirm that she has constitutional mismatch repair deficiency. So her test results revealed that she has two PMS2 pathogenic variants. And importantly, this is a recessive condition. So when we diagnosed this, we also found that each parent has a PMS2 mutation, and therefore each of them have a different cancer predisposition syndrome called Lynch syndrome. So we'll talk a little bit more about that. So CMMRD is associated with mutations in mismatch repair genes. And unlike a lot of the cancer predisposition syndromes that we work with, this is a recessive condition. And in contrast to Dicer1, the cancer incidence, or the childhood cancer incidence, is incredibly high. We think 90% of children by age 18 will develop a cancer. This is also unique for hypermutator tumors, right? So those tumors Dr. Nichols mentioned that have hundreds to thousands of mutations that make them amenable to immunotherapies. Dr. Nichols has shown us some of the key categories of tumors that occur in this syndrome. Just a very wide range of malignancies, though, have been reported. And so certainly continuing to learn more about this condition. Also important, which was shown with Elizabeth, right, is non-malignant findings, in particular skin. So children with CMRD can have various hyper and hypopigmented skin lesions. They can also have findings that mimic NF1. And so the skin is usually one of the first features that we can see in children with CMMRD. Family history, we've discussed that consanguinity is important to ask about if we're considering this condition, and also paying attention to Lynch-associated cancers or colon polyps. So Lynch syndrome, we think about colon, we think about female reproductive tract cancers. And so paying attention and asking about those, recognizing the family history rarely meets Lynch syndrome criteria. The family history may not be super significant. But when we make a diagnosis of CMMRD, we also are making diagnosis of cancer risk in the parents through Lynch syndrome. There are resources to be able to think about whether testing is warranted for a child with cancer for CMMRD, but also clinical criteria that can be used to further evaluate this condition. And so given the significant cancer risk, there are surveillance tests that we do very regularly and quite frequently where available for CMMRD. Elizabeth was undergoing surveillance and over time was found to have multiple adenomatous colon polyps and a glioblastoma lesion. And so just to close the loop and remind you, having the underlying CMRD with the glioblastoma, that tumor biology made her eligible for targeted immunotherapy, in this case, immune checkpoint inhibitor therapy. Okay, lastly, we'll talk about Henry. So Henry came to our clinic at age 2 months with unilateral retinoblastoma. And in contrast to Nathan and the family with Dicer1, his parents asked us, there's no family history. So across 3 generations, there was no one with cancer, no one with retinoblastoma. And so the parents were curious, there's no family history. Why are we considering, or why are we thinking about genetics here, or cancer predisposition? For Henry, we did have the tumor sample. And so the tumor sample was first used to identify those 2 hits in the RB1 gene that follows that 2-hit model of tumor formation. And from there, we were able to use a blood sample from Henry to check for the tumor RB1 mutations. In his blood sample, he was confirmed to have one of those RB1 mutations, consistent with a diagnosis of hereditary retinoblastoma. And so his story, or his family, shows us that his parents both tested negative, his siblings tested negative for RB1. And so this is one reason, right, why we see there's no family history, because Henry was a de novo occurrence, meaning most likely he's the first person in his family with hereditary retinoblastoma. But moving forward, right, this is important for his care. So hereditary retinoblastoma is a dominant condition. And in contrast to Dicer1 and CMMRD, most of the time, it's de novo. First person in the family with it is the child. The cancer risks approach 100% for retinoblastoma for most mutations, but there are other cancer risks that we think about over the child's lifespan, including brain and then later on, muscle and bone sarcomas and potentially other cancers. And so where possible, we try to do tumor testing for evaluation. And importantly, all children with bilateral disease have the genetic condition, but an important subset, maybe 15 to 20% of children with unilateral disease also have the genetic condition. So that's, Henry highlights that very well. For surveillance, ocular surveillance is key, but we also look at other body areas and really do thorough physical exams and educate the family on important signs or symptoms. So Henry underwent surveillance and was found over time to have retinoblastoma in the other eye. So I recognize, again, this is a very broad overview talk about these concepts and about genetic counseling. So if you're interested in delving in further, I recommend you check out my colleagues and my papers on genetic counseling practice and also recommendations we have in working with this population. So we take you through the sort of the span of a patient's journey, right? Whether that's right at cancer or cancer predisposition diagnosis, but also through childhood, culminating in transition, right? So making sure that the child is aware that they know they have this cancer predisposition and helping support them to transition to adult providers so that cancer care, that cancer surveillance can continue. So we are very thankful to you. I'm going to hand it back over to Dr. Nichols to wrap us up.
All right, everybody. So in sum, and as we've tried to point out, predisposition syndromes, do affect a significant proportion of children with cancer. And honestly, as new genes are discovered, so will new phenotypes emerge. Referring is warranted for children with specific, medical, physical, and tumor features, as Rose discussed. Germline information is definitely enhancing the care of patients with cancer by improving our understanding of biology of the cancer, its treatment, screening, and hopefully in the future, better preventive measures. And together, I know that we can further advance the field with the overall aim, of course, to improve the lives of affected children and families. And before I close, I wanted to bring to your attention that we will be holding a St. Jude Cancer Predisposition Symposium on October 14th and 15th, 2025. And this symposium will feature, internal St. Jude presenters as well as external speakers. It's a free symposium. There are virtual as well as in-person opportunities. And so please feel free to attend. Registration is now open. Please also spread the word amongst your colleagues. We welcome you all to attend this symposium. And finally, I close by thanking you for your attention, our team members and collaborators, without whose hard work some of the work that we discussed today would not have been possible. And of course, all our patients and families who serve as the inspiration for Rose and me and the rest of our team to keep pressing on in this field. So thank you so much, everyone, for your attention. I realize we've completed the time, but we will welcome any questions. Thank you very much.
Thank you so much, Dr. Nicholas and Ms. McGee, for the insightful presentation. We will now open the floor for questions from our audience. If you have any question, please use the raise hand feature or type your question into the chat box. We will address as many questions as possible within our allotted time. Let's start with the first question.
I guess, can I ask the audience? I'm not sure if they're willing to speak, but are there opportunities for evaluating children with for potential cancer predisposition or opportunities for testing in your country? I'm not so familiar about what's available.
Okay, so Dr. Nicholas, thank you so much once again,
Okay.
Ms. McGee. Oh, I guess we have a question here in the chat box.
Easy.
Let's see. How do you deal with VUS and genes related to a disease condition? So that's a very good question, and Rose is here with me. So we have seen quite a few variants of uncertain significance, and as you can imagine, the more genes you look at, the more likely you are to find variants of uncertain significance. And as Rose mentioned, most often this is because it's very limited evidence that's available to support potential pathogenicity. When we see a VUS, I mean, most of the time, 85% of the time, these are eventually downgraded to, benign variants or likely benign. So normal variants, one person to the other. But, there is a proportion of VUS that could theoretically, be important for the child's health. So what I generally do is, is the VUS in a gene that is relevant to the patient's tumor? So let's just say we have a VUS in the WT1 gene, the Wilms tumor gene in a child with a Wilms tumor. If I was to see that, it might raise a red flag. I want to really look at that variant closely. And so then, what we often do is we look to see where in the gene is the variant? Is it in a critical portion of the gene? How does it impact the amino acids? Are you changing from an amino acid with one physiologic type to another? We often reach out to experts in the field related to that specific condition and try to put the information together. Now, that said, it's pretty rare that we actually use the information to change treatment or test other people in the family. It has happened every now and then where we have done that. I can give you an example where we had a child with a P53 variant, and we still recommended, Li-Fraumeni type surveillance because there was a strong family history. One other thing I would like to emphasize is that occasionally, if you can do genetic testing for other people in the family, new information can come to light that if then fed back to the genetic testing lab might spur them to upgrade the interpretation to likely pathogenic. So most of the time, we don't change therapy, but these are ways that we might look at a VUS or consider using it to guide clinical care. I hope that addresses your question.
Okay.
And Rose,
yeah. So thank you, Dr. Schutz. You're asking for those who want to obtain certificate in genetic counseling practice, what will be your advice? Highly dependent, right? So some of it depends on in your country, what is the recognition of genetic counselors as practicing providers. Now we absolutely have had people come from all over the world to get the training or the certification degree in genetic counseling. So there's a number of programs in the United States, in Canada. I know there's at least one in South Africa, and there's other areas in Europe as well. And they're all a little bit different and have different governing bodies. And so that would be where to start, is to think about where is there a program nearest to me, or where would it be feasible to do the training. Most programs are a master's level is the highest level of degree. And so they're usually about a 2-year full-time program. Okay. Oh, yeah. So, yeah, we have a question. How does pharmacist-led monitoring of adherence and toxicity impact the long-term outcomes and recurrence rates in pediatric cancer?
That's a very big question. Yeah. Oh gosh, I don't even know how to address that question. I mean, I know that there are, there's a huge survivorship program here that collects all this information and studies it and its impact on cancer outcomes. We don't have a whole lot of information as relates to that question with patients with underlying genetic predisposition. So it's hard for me to address that question. I don't know, Rose, if you have any specific thoughts. I wish I did. But I know that that's a big part of what, the various oncologists carrying out clinical trials obviously have drug diaries, right, where they collect information on whether patients are taking their drugs. And obviously, if they miss a certain proportion, that's a challenging issue. But that falls a little bit more in the domain of our survivorship program. And so I apologize. It's not my area of expertise. I'd have to look into that and I could get back to you.
Hello, no problem. This is Mace. I practice in the Advocate Health, Charlotte, North Carolina, and our oncology pharmacist we're always on the part of the team. So I wanted to know Jude, how do you also
well, there's definitely clinical pharmacy, right, that participates in the active oncology care for the patients on the different teams here. So I know that, obviously they're going to monitor drug dosing and the numbers of doses that they get. And there's a lot of interest here, of course, in pharmacogenomics and how germline variants in some of the pharmacogenomic genes might impact responses to certain drugs. That falls a little bit more in what used to be Mary Relling's, domain, and now Serene Hydar's expertise. But the pharmacists are definitely clinically integrated into the active oncology treatment teams. We don't have them come to our clinic, so I can't speak as much on that.
Thank you very much, and thank you for the great session. Thank you.
Yeah, I appreciate it. Thank you. Thank you for attending.
Another good question, you and I.
Oh, how do you approach disclosing genetic test results? Oh, that goes for you, Rose. I'll let you address that one.
We do it as a team.
You're the genetic counselor.
Yeah. Some of it depends too on did we meet the families before the testing was ordered, or are we seeing this family and the test has already been done? And so that sometimes can impact the conversations. Yeah. So just like any potentially bad news, right? Is we take it slow. We try to meet the family where they are, and we have the privilege, the luxury of, often these children are on therapy, so they're coming often to the hospital. So we can try to see them more than once, right? Multiple times to just help them walk through and talk about what is the most important thing to them right now about these results, recognizing we can try to take some time to get to some of the longer standing or the kind of downstream things that we'll want them to know about it at some point. But yeah, those are some approaches. Just again, trying to work with the family and meet them where they are is, I guess, a big thing. I don't know if you have something to add.
Well, it's interesting, Dr. Roched. When I first came to St. Jude, essentially all the germline genetic testing was done by my team and the genetic counselors. And we would meet the families ahead of time and we would inform them about the genetic test and what the types of results were. And it was really, what I believe to be a very well-informed consent process prior to germline genetic testing. And over the years, the approach to genetic testing at St. Jude has changed, as it has in several other centers in the United States and around the world, where now, patients are offered paired tumor normal testing at the point of diagnosis by the primary oncology team, and not by the genetic counselors necessarily. And often this happens right at the time the cancer is diagnosed. So there's a lot going on. The patients are undergoing biopsy, maybe initiation of therapy. There's a million consent forms they have to sign. And I have to admit, I was kind of worried that families might not understand what they were consenting to, and it might be more distressing if later they learned that there was a predisposing variant. And what we've seen over time, it's very interesting. So the way that this now works is once the results come back in the medical record, our team sees the patients post-testing. So it's a little bit different a model. And surprisingly, I mean, my experience, and I can ask Rose, has been that most parents tend to handle it much better than we thought. They remember that they signed a consent. There is an informational video, which some of the families have seen and they recall. And I think they're very appreciative of getting the information, particularly as it might help them to better predict, whether the child's at risk for other cancers. It gives them the power to implement surveillance. And many of them really want to know, what about the other children? So it kind of empowers them to test the other kids. So honestly, it's as Rose said, we try to take it slow. And I think many families opt for this testing and handle it much better than I had originally expected. Oh, look, thank you, Dr.
I put a resource in there. about genetic counseling programs throughout the world.
That's great. Thank you,
Mhm.
Rose.
Well, thank you so much. Marie, are you here?
Yes, ma'am. Thank you so much, Dr. Nicholas.
Yeah.
And Dr. Thank you so much for this presentation and thank you so much for answering the questions. It was a pleasure to have you with us. Thank you all for attending. We hope you found it informative and enjoyable. Have a great day.
Yeah. Thank you all.
Thank
you.
Appreciate it. Have a
Bye.
wonderful evening. Take care. Have a great
Thank
weekend.
Thank you.
Have a good
Bye-bye.
day. Bye.
Bye-bye.